Now see the complications, as you know. It is a part of the surgery. Complications and problems is a part of everyday surgery. If you are not getting the complication, then you are not operating, or then you are a surgeon above human being. So, and the complications are more for the beginner. So, whenever the beginner is making the complications, then we will have to show his video to him so that he can improve. Prevention is better than cure, and to anticipate the complication, it is to take measures to prevent the complication. So, what is the senior surgeon? That he anticipates the complication and he can prevent the complication. Now see, so many wound related, rhexis related, arrow dissection, nucleus management, and then due to the instrumentation. These are the complications which you can see. Now here the posterior rupture with or without vitreous loss, post-op problems and corneal complications. You can see these things. Now here, now the too long corneal folds, less visibility. If you are more inside the cornea or beyond the sclera, behind, on the both the sides, visibility is reduced. So it should be optimum. 1 millimeter inside the cornea, 2 millimeter behind the levers. Too short. If it is too short, you will have to take sutures. It is not safe anymore. Then too wide, the astigmatism okay, but iris prolapse happens. You will see iris coming out and difficult to operate. Then as you know, the two posterior, that is called as overlap, and two forward corneal folds. Then here you can see there is a on my left you can see there is a buttonhole. Can you see that? So buttonhole can happen. So you have to just go behind that buttonhole. And you see now here, buttonhole is seen. So whenever there is a buttonhole, then that may not heal, or that may be a menace for the infection. So from that infection to go in. So for that you have to go behind, or otherwise suture the buttonhole. Now there may be a deep scleral, this insertion, edema or perforation can be there. Then the wound construction, you have seen wrong shape. If it is a smile, astigmatism is much more. Then here the premature entry, I have told you, once there is a premature entry, normally it is because of the deeper incision. So there is a one wound which is in blackish in color, I think incision. First of all do one thing, suture that blackish color without doing anything. Once you suture that, then you can go ahead and do the tunnel in the same place. But if it is not possible, first change the side and suture previously. If it is not possible on that side, then go slightly up in the whatever the incision you have taken and make a superior tunnel. It is thinner superior tunnel and lower part you should suture. But this you should do before opening the eye, and once you open the eye, there is only one enemy, that is called iris. This iris will not let you do anything. He will come on all the part and it is very difficult to operate. So always remember, tackle the, now this video is not running, there is some problem in the Apple. So I want to show you how iris troubles you. This was the video of troubling iris to the surgeon. So much trouble, but lastly I have suture, but you will see horizontal border of the iris. Why? It is because of two. One is iodialysis or more handling. So that can cause such type of thing. So beforehand only you will have to. Now here, two narrow incision, you place more than incision size, it will not come out. Extended. Now see, the extension. Extension means, whatever you are extending for that, I always say, your back cut should be slanting. It should be like this. So if you want to extend, you can do. If it is straight, you can't extend. If it is slanting, then you can extend on this side and this side. So you must know in few cases, if it is a mature cataract, hypermature cataract, or the black cataract, your incision when you are extending behind, it should be slightly slanting on the temporal and nasal side, and that will help you for the extension of the wound. Then that I have told you how to go ahead. Then the iris injury. So always you see the iridodialysis. What happens? If there is a iridodialysis, it has happened, suture it. Without suturing, don't proceed. So iridodialysis, on the table you can see the circular pupil. Second day, upper edge is horizontal. After 7 days, that edge comes inside the pupil, and after few days, pupil is not seen. In the upper part, you can see a pupil which is behind the margin where there is arcus canalis, and patient can't say anything. So it is better to suture, and you can see the iris may damage. Secondary meiosis. Now what happens? We always feel if it is a resident is not instilling or some our person is not instilling the draft. No, it is because of the meiosis on the table. Meiosis on table is because of handling in the eyes, not because of less medicine or they are not put the blood or anything. No, it is just handling, and that handling can cause such type of thing in the procedure. Now here the rexis, if it is very small, then you will have to extend. Once you extend, then there is no any you can say the concept of the bag. So beforehand only your rexis should be larger than the phaco. Why? Because in the phaco you are making the pieces. Here you are removing the nucleus. Nucleus is 7 mm by 4 mm. 7 mm by 4 mm, larger in size, and because of that it should be minimum 6 mm rexis, minimum 6 mm, and that will help you. So the capsular, now here the flaps escapes, and these flaps, whenever you are aspirating, they are dangerous. So flap will bring out the capsule, and you will think that why capsule is coming, there is a you can say the some type of zonal dehiscence or like that. No, it is not like that. It is happening because of the capsule you have cast that flap. So this capsule extension or tears or can cause the PC tear. So anything anterior trouble can cause posterior trouble, that you should know. Now again the hydrodissection. Now in the hydrodissection, whenever you are doing the hydrodissection, here the incomplete nuclear separation is the most troublesome. The need prevent the rotation, and excessive. If you do excessive, then what happens? The nucleus come up and anterior chamber becomes shallow. Always remember, when anterior chamber is shallow, the vitreous is pushing the nucleus. It means vitreous is not in the behind the PC, but it is in the anterior chamber. And so at that time you feel, why this is happening? Nothing. There is a PC tear behind because of the over hydrodissection. Then the management, maybe it is difficult due to the dissection, small pupil, small rexis, zonal dialysis, PC tear or nucleus drop. So these things can happen, and if it happens, then it is very difficult. Now here, the inadequate external incision causes definitely difficulty. So it should be an adequate external PC tear without vitreous loss. May trouble you. That I am going to show you. Now here, this is the posterior capsular rupture with or without vitreous loss, and can occur at any stage as mentioned above or during the irrigation time. So that I will show you here. If there is a, I think this video is not running. Yes. Now here you will see this is the PC tear, and because of the anterior chamber seen now here, I am cutting the flap. Can you see that? The flap I am cutting. This is the flap of the anterior capsule, and here I have made the mistake. Here I have made the mistake because I have cut that. At that you can see now the crumpled capsule. Crumpled capsule. It means there is a PC tear and I have not seen that PCC now. It is because of the capsule. And I am removing everything. Why? Because you can see now the PC is tear and I can remove because of the AC maintainer. Vitreous has still not come out, but vitreous may come anytime. So whatever I am doing is just because of the AC maintainer. I have just raised the height so that the anterior limiting membrane of the vitreous remains, and see here the capsule you can see, and I have implanted the lens in this without doing vitrectomy because vitreous is not in the anterior chamber. So that you can do, and you can see the pupil is constricted or not, and if it is not, then again you will have to go for the vitrectomy. Now here you will see, and you can see it is free of the vitreous, and I am just implanting this in the sulcus. Of course it is not in the back, it is in the sulcus. See here, and you can see the circular pupil, and that finishes the. Now this is the another PC tear again that is seen in this one, and which you can see now. I remove this, but there once I remove this liquefied cortex, you can see that this is the lens coming out. Here, once it has come out, I have not noticed this, but here you can see, that in the superior there is a PC tear. So that also you will have to see. And now the another is a posterior capsular rupture that we have seen. Then the with or without vitreous loss, that also we have seen. And then corneal complications that we have seen. This may be now we have seen that. Now I will show you the last complication, for everybody is worried for that, and this is called as the nucleus drop. Now see, this is the case I am operating. You can see this is a nuclear cataract with the pseudo exfoliations. Can you see? I am trying to bring this nucleus inside the anterior chamber because of the rigid pupil. See now, and the AC maintainer is now. It is a slightly dilated pupil. I am trying, and now see the vitreous, the nucleus has gone behind. So here, once nucleus has gone behind, always remember, which is not possible, so keep you cool. Forget that nucleus has gone behind, because there are so many retina surgeons in India, they will require some of the things. If you will eat everything, what he will eat? So, and another thing is, whenever retina surgeon operates, there is no any cold case. I will tell you why. Because he operates for 3 hours. He takes the time, too much time. Patient is very happy. He will tell, he tried 3 hours, he has operated me, but I am not having vision. That is my bad. But if you cataract surgeon operates in 10 minutes, you say, he has not given me time, and because of that my eyes are lost. So always be cool. Ask retina surgeon to operate. Another thing is, don't put any type of thing. That so many instruments are there, and they are there in the cataract. So you will put this, that, and then what happens? Once the vitreous fluid is damaged, you damage the retina, you damage everything. See, this can be treated by the retina surgeon. Excellent, patient will get vision. In this case, patient was having 6/18 vision and he is happy. So, the take home message is, though it happens, just keep a cool. Now the conclusion is, the surgeon must have thorough knowledge of all the possible complications, problems that may arise during the surgery, so that they can minimize the incidence of their occurrence. And if they do occur, he will know how best to manage them. And And if you know that, then there is no problem. Thank you very much. Thank you very much. I have some. We have finished our time. Thank you.
Triple helical structure, and this structure is maintained by interpeptide hydrogen bonds. This molecule has amino and carboxy terminals, and all this chemistry is important because this is at this level that the cross-links actually happen. Once we have the tropocollagen molecule, thousands of them align parallelly to create the collagen fibers, and these fibers are then arranged in a hexagonal lattice array in lamellae. These lamellae run from limbus to limbus in the cornea and are stacked one on top of the other, and we know that they are more dense in the anterior cornea and less dense and more regular in the posterior cornea. It is this regular arrangement of all of these structures that allows us to have corneal curvature and clarity for perfect vision. It is as yet unclear at what level in this architecture there is a defect in keratoconus, but we do know that this defect results in a loss of rigidity, thinning, and a protrusion and loss of shape with resultant poor vision. Just as we do not know what goes wrong in the cornea and keratoconus, it appears that we also do not know exactly what it is that cross-linking does to address this defect that allows us to stabilize the cornea in these eyes. But by and large, it is now generally understood that this process increases the corneal rigidity, although we are not sure exactly at which level in the keratoconus pathway it works. What we actually do with cross-linking is to use ultraviolet ray radiation at 370 nanometers, and when we apply this to the cornea soaked with riboflavin, the excited riboflavin is able to produce reactive oxygen species and oxygen and superoxide anions, and these reactive molecules are what induce covalent bonds between the amino terminals of the collagen molecules, resulting in an increase in rigidity, and this happens by means of a type 2 photochemical reaction. If we look at the procedure itself, it is best to perform this in the operating room because there are increasing reports of infections after this procedure, and this is perhaps not surprising considering that we create a fairly large corneal epithelial defect and we leave it exposed for significant amounts of time. It is therefore important to pay attention to the draping of the lid margins with your plastic drapes, and then the standard protocol that we've been following all along, which also is called the Dresden protocol, we use riboflavin 0.1% with dextran. We apply it every 2 minutes for a period of 20 minutes, and then irradiate the eye with ultraviolet for a further period of 30 minutes, during which we again apply the riboflavin about 10 times once every 3 minutes. Topical anesthetics and antibiotics are used as required. In a variation of this procedure, some surgeons prefer to leave the epithelium on and do not try and remove it before applying it. And if you're doing this, you need a special riboflavin which has some epitheliotoxins in it, which allow it to penetrate through the intact epithelium. Obviously, the reason for performing the epi-on procedure is to try and reduce the risk of infection and to increase patient comfort in the post-operative period. Whether this works as well as the standard procedure, we'll see in subsequent slides. And just for nomenclature, today we call the epi-on procedure as C3R and the more commonly performed epi-off procedure as CXL. Another variation is the use of riboflavin without the dextran, and this so-called hypotomic riboflavin allows you to treat corneas thinner than 400 microns up to a thickness of 350 microns, because with the standard riboflavin we generally will only treat corneas thicker than 400 microns. In the stromal level, when we do the process that we just saw in the previous slide, what apparently happens is that there are cross-links or covalent bonds that are formed between the amino groups of the adjacent collagen molecules, and this occurs both intra and interhelix. It also occurs within and between lamellae, and all of this is what contributes to the increase in corneal rigidity. And this was how we traditionally believed when we started cross-linking that it worked. Newer research now indicates that we can also have tyrosine cross-links, and histidine residues in the cornea may also part in this process. Also, we can have advanced glycation end products, and these we know occur both naturally in the aging cornea and in diabetics, and these have also been invoked to play a role in therapeutic cross-linking. Finally, a recent paradigm shift has been the belief that non-collagen molecules, typically the glycosaminoglycans in the stroma, the dermatan and the keratin sulfate, may also be involved in therapeutic cross-linking to help increase corneal rigidity. But despite all of this, the precise mechanism, as I said before, still remains unclear. So what exactly happens in the cornea is a photochemical reaction, and although we don't like biochemistry much, I'm forced to talk about this because this is the basis for the ongoing controversy about accelerated cross-linking, and therefore it makes sense to try and understand what exactly happens in the corneal stroma. There are two types of photochemical reactions that occur. In the type 1 mechanism, this can occur at low oxygen concentrations using radical ions to cause cross-linking. The type 2 mechanism is a far more rapid and explosive process, and this needs excessive amounts of singlet molecular oxygen. So as I said, the type 2 reaction occurs at the start of ultraviolet irradiation. It's a very rapid response, occurs within 10 to 15 minutes, and depletes most of the singlet oxygen that is present in the cornea, and subsequently cross-linking can only occur because of the type 1 reaction. In about 10 to 15 minutes, there is sufficient reaccumulation of oxygen that you can have a second burst of a type 2 reaction. So if you do believe that the type 2 reaction is the most important part of the process and that oxygen is required for the stromal cross-linking, then it makes sense not to reduce the time of treatment excessively. The initial indications which we started with for this process included progressive keratoconus. We then added pellucid marginal degeneration and post-eczema ectasia. More recently, it has been used in infectious keratitis, and here, while the cross-linking can cause stromal compaction and counter the melting that occurs in an infective keratitis, it is the DNA and RNA damage induced by the ultraviolet light that decreases the organismal load. It has also been recently tried in bullous keratopathy because people hoped that the anterior stromal compaction from the cross-linking could help reduce symptoms from the corneal edema seen in this condition. And while it does seem to work in the initial phase after cross-linking, most studies now report that there is a gradual loss of effect, and maybe this is not such a good outcome or indication for cross-linking. So if we look at the results, and there's plenty of it in the peer-reviewed literature now, and this is a very recent article published in Ophthalmology in January of this year, you find that there were 100 eyes that were randomized to treatment or no treatment in the fellow eye, and the Western protocol, which is the classical protocol we all started off doing, was used. 30 minutes of ultraviolet exposure with an intensity of 3 milliwatts per square centimeter. And in this study, the maximum sync-K, the unaided vision, the best corrected vision, the refraction and tachymetry at 3 years follow-up all improved in the treated group but worsened in the control group, indicating that standard cross-linking does indeed work in arresting keratoconus progression. As with all procedures, you can have complications with cross-linking as well. I did mention infections before. You can get corneal opacities, particularly if your machine is not being calibrated properly and you're delivering more energy than you should, or you're closer to the cornea than you should be. You can get persistent edema for the same reason when you have endothelial damage from the radiation. You can also get persistent epithelial defects sometimes, and current evidence indicates that in up to 5% of eyes, there could be a progression of ectasia despite adequate cross-linking. One of the things that has bothered surgeons is the duration of the procedure. We have to do this for about an hour. This is quite uncomfortable for the patient and does increase the risk of infection. And therefore, it kind of makes sense if you could have a shorter procedure where the eye is not exposed for long periods of time. And that is the basis for accelerated cross-linking. The photochemical basis for this process is the Bunsen-Roscoe law of reciprocity, and this states that in a photochemical reaction, if you can deliver the total amount of radiant energy and keep it constant, then you should get an equivalent effect. Now this amount of radiant energy in the cornea can be delivered as a product of the intensity and the exposure time, and if this law applies to the cornea, you could titrate these parameters but get an equivalent effect as long as you maintain the radiant exposure. Let's make this a little clearer. We've been doing the standard Dresden protocol with 3 milliwatt intensity for 30 minutes, and this gives a total radiant exposure to the cornea of 5.2 joules per centimeter square. Now if we apply the Bunsen-Roscoe law, as long as you maintain this radiant exposure at 5.4, you can interchange the other two parameters and deliver 30 milliwatts of intensity for just 3 minutes and achieve the same benefits. This is a machine that Appasamy Associates have made to conduct this procedure, and it gives you a system that allows you to deliver between 1 to 8 milliwatts per centimeter square of intensity for a duration of anywhere between 1 to 99 minutes, which can be titrated, and this is quite a user-friendly machine. There is some uncertainty though. The Bunsen-Roscoe law applies to chemical reactions in inorganic substances, and in an organic situation as in a human cornea where we are doing cross-linking, there could be a therapeutic range or a threshold which if you violate, the results may not be optimal. If we look at the available evidence, this is from Rockin's group. They had an ex vivo cosine corneal model where they used strips of pig cornea to do a standard treatment with 3 milliwatts for 30 minutes, an accelerated treatment with 10 milliwatts for 9 minutes, and a control with no ultraviolet treatment, and they then performed stress strain measurements to determine the Young's modulus, which increased by a factor of 1.3 in both the treatment groups, indicating that the corneas did stiffen while there was no change in the control group. Statistically, there was no difference between the Young's modulus in both the treatment groups, meaning that an accelerated procedure using 10 milliwatts for 9 minutes was effective ex vivo in this porcine model. The caution, however, is that the cornea tends to react to everything we throw at it, and therefore we should be a little careful in applying a law that applies to inorganic chemical processes to the human cornea. And in this interesting study, where they doubled the radiant exposure to 10.6 joules by applying 3 milliwatts for 60 minutes, there was actually no effect on corneal rigidity, meaning that whatever crosslinks occurred in the first 30 minutes were deslinked or delinked in the next 30. Therefore, we do have issues about applicability of this law to the human cornea, and some experts have voiced concern about exposing the cornea to increasing intensities of radiation because of endothelial safety concerns. This is a more recent advance, and therefore there are not as many studies published in the literature. This is a small series of 7 eyes in a prospective cohort study, which was treated with 18 milliwatts for 5 minutes, and the authors indicated that the procedure was quite safe. The corneas healed quite well, there was no endothelial damage, and at 6 months follow-up, all the parameters remained stable. If you look at the confocal evidence of what happens in the cornea following such a treatment, in 5 eyes which were treated for 10 minutes with 12 milliwatts and another 5 eyes which were treated for 4 minutes with 30 milliwatts, confocal microscopy revealed a depth of penetration of these changes of about 160 to 180 microns. Now, if you look at the original Dresden protocol treated eyes, the depth of penetration is 300 microns. But again, most people tend to believe that a 180 micron penetration should be good enough for clinical cross-linking and corneal rigidity improvement. Interestingly, in the same study, 5 eyes had the epi-on procedure, meaning that the authors did not de-epithelialize the cornea, and flash-linked it with 45 milliwatts for 2.5 minutes, and in this, the depth of penetration was only 80 microns, which probably is not good enough for clinical cross-linking and rigidity improvement, and this is probably why today most surgeons perform the epi-off procedure and the epi-on is not as favored. With the advent of this procedure, the indications have expanded. We now can do what is called topo-PRK, where we do in keratoconus a surface ablation which is topography guided and cross-linked simultaneously. Although we must be clear that we are not doing this for refractive reasons, we are only doing this to normalize the corneal topography and make it a more homogeneous surface. I've already alluded to the controversy between epi-on and epi-off, and another version is what is called CXL plus LASIK or LASIK extra, where after you do your standard LASIK procedure, you expose the stromal bed to riboflavin for 1.5 minutes and then flash link for a further 1.5 minutes, hoping that you can reduce the risk of ectasia, particularly in predisposed eyes. Studies are also undergoing with hyperopic LASIK, which traditionally has extensive regression, to see if cross-linking can freeze the cornea after LASIK and prevent this regression. In children, we are doing it, although there are debates still ongoing on that. So if we come to the current status and try and summarize what it is we've seen in the last 15 minutes, basically the exact mechanism of cross-linking is still unclear. Accelerated cross-linking, the parameters are still being titrated, and there are obviously many advantages to shortening treatment time. This includes increasing patient comfort, reduced infection risk, and greater throughput for the surgeon himself. And while we have enough data to show that the evidence supports the safety of accelerated cross-linking, the efficacy and the long-term outcomes are still being studied. My personal experience is with the Apasami prototype machine for accelerated cross-linking, and I've been using it for the past 6 months. We've treated over 50 eyes. My protocol is 15 milliwatts for 6 minutes, and all of these eyes have healed very quickly. There's been no corneal epithelial change, there's been no stromal haze or endothelial damage. These eyes are exactly like the 400 eyes that I've treated previously with the standard President protocol. Over the last 6 months, none of these eyes have shown any progression, but obviously to make a more forceful statement regarding that, the longer follow-up is needed. So in conclusion then, I think the accelerated approach to cross-linking does appear to work. However, if you go into the basic biomechanics, and there is the debate about the mechanism of action and the need for oxygen in the stroma during the cross-linking, it may be prudent to try and not shorten the treatment time excessively at this point in time, but rather to wait for more evidence. At the moment, treating at about 6 minutes appears safe and effective, but doing it for 1 minute may be pushing things a little bit. The potential for complications exists, as with the standard approach, even with the accelerated approach. And from the literature, at the moment, LASIK extra or combining accelerated cross-linking with LASIK, there is no convincing evidence to support its use. Before I end, I'd like to invite you all to the second meeting of the National Corneal Society. This is called Caracon 2014, and it will be in my hometown of Chennai. This is in December at Mahabalipuram Beach Resort, and we will have sessions on cross-linking there as well. So all of you are welcome to that meeting. Thank you very much. Basically, I think as long there have been people who are trying to devise metal rings that can be placed around the limbus when you're treating. But as long as you are focusing the device very carefully, because ultraviolet has a very short spread, it really doesn't have a wide spread, I think you're quite safe. I don't think the accelerator
which increases or decreases rather the threshold of UV damage, and it brings down the threshold of UV damage to as low as 0.35 milliwatts per centimeter square. So exactly why are we putting riboflavin? It is actually increasing the toxicity of UV. The reason we do this is first because of the singlet oxygen radicals that are formed, and second is because the riboflavin acts like a UV sink. It absorbs the UV and limits the transmission of UV to the anterior layers of the cornea. It does not allow UV to cross beyond the endothelium. So this is the significance of riboflavin. It has a dual role. It helps in the formation of the oxygen-free radicals, but also at the same time, it limits the UV dosage and the UV effects to the anterior portion of the cornea, and therefore, that is the reason you don't see patients developing cataracts after cross-linking, because otherwise, theoretically, the patient should have developed a cataract, and the patient probably should also have developed a macular hole from looking at UV radiation for half an hour continuously. This does not happen because of the protective effect of riboflavin. Now, normally the cornea we know absorbs approximately 30%, and the lens absorbs an additional 50% of UVA. But this is what I said, the photosensitizer riboflavin increases corneal UV absorption, and at the dose of 0.1%, which is at which it plateaus off, if you increase the dose of riboflavin more than 0.1, it doesn't really cause any greater increase of UV absorption. It just plateaus off at 0.1%, and that's the reason we use 0.1%. So 95% of UV is absorbed within the cornea, and this brings down your surface threshold level of 3 milliwatts per centimeter square to about 0.15 milliwatt per centimeter square at endothelium. So even though you are applying 3 at the surface level, by the time you reach the endothelial level, it has come down to about 0.15 milliwatts per centimeter square, and the toxic level for endothelium is known to be 0.36. So now you know that we are well below the toxic level for the endothelium, so you are safe to go ahead and do your cross-linking. Now all these values apply when you are having a cornea of sufficient thickness. You have to have a cornea of sufficient thickness if you are going to go by these values, that yes, you have decreased your UV radiation to 95% by the time you are at the endothelium. Now what are the indications? Lots of indications for cross-linking, especially it's such a very, very exciting phase of development. joules. So that is the aim. And you can play around with your power and your time so that you still are at 5.4 joules, but your power might be more, and as soon as you increase your power, you automatically need to decrease your time. Because if you have a high power and a high time, you may overshoot the same level of 5.4, and then that is when you start getting problems. So if you're increasing your power, decrease your time, and if you're decreasing your power, you will have to expose the cornea for an increased period of time. So this is the new model of the AIOC cross-linking machine, which I think they've termed as a UV-CL machine, and it is a very, very nice machine. I'll just show you some things about it. The good part of it is it's got a high safety profile because the power and the energy are adjustable, and they don't allow you to have a combination where you have exceeded 5.4, so it automatically stops at 5.4. You have a wide range of powers from 0.7 to 30 milliwatts per centimeter square, so you can go all the way from 3 milliwatts, the traditional resident protocol of 3 milliwatts for 30 minutes, and you can go as high as 30 milliwatts for 3 minutes if you're doing accelerated cross-linking. The UV they use is 365 nanometers. We've got a nice working distance, 8 centimeters, which allows you to do whatever maneuvers you want to do under it without making the procedure unsterile. We've got nice aiming beam, which is not there in the original model, which really makes it very helpful to focus the beam properly onto the cornea. And it's a homogenized radiation system. And the other good thing is you have a linear diameter control. So it's a linear diameter control, so you can actually increase and decrease the diameter as you would want. So if you want to create a larger zone, you make it into a larger diameter. Or let's say you're doing a cross-linking for a corneal ulcer. You don't really want to expose this entire cornea to the UV. In that case, you select a smaller zone diameter and you expose only the area of the corneal ulcer to the cross-linking. So the other things, of course, are motorized focusing, which is again good because the old one was a little bulky and you have to actually move it by hand up and down. The motorized foot pedal control gives you much better control over it, and you have a video display, so you don't have to keep peeping underneath to see what's happening. You can automatically see on the video what is happening, and it's easy to transport because I think they're coming out with a table mounted model as well. Post-treatment, what you do, you put the patient on VCL, give them topical antibiotic steroid combinations. You also put them on vitamin C. Ask them to wear UV protective glasses when they go out, and then you remove the contact lens once the epithelium is clean. Now, of course, there are lots of combination treatments available where we combine, and I also do it intact along with C3R. And the way to do it is always you put the intact first, followed by the cross-link. You can do sequential or simultaneous. I prefer simultaneous. I put in the intact and simultaneously do the cross-linking immediately after putting the intact. If you don't want to do that, you can do sequential in the sense you do intact first, followed by cross-linking. But you never do cross-linking followed by intact because this intact is not going to work well if you have already strengthened the cornea, its rigidity has increased. The whole purpose of putting intact is to shift the cone. You try and shift the cone to as central as you can get it, and if you increase the rigidity of the cornea, the intact is not going to have the effect of shifting the cone. So you never do it in the reverse order. And intact per se is a good option. I've done it, but I generally tend to, in younger patients, always combine it with cross-linking because even though intact improves the biomechanical effects and also decreases progression via the biomechanical effects by breaking the cycle, it does not decrease the progression to the extent that cross-linking is known to. So the ideal combination therapy would of course be combining. You can also do a combination of cross-linking and pachykyval, where you do cross-linking, stabilize the cornea, wait for 3 months or 6 months, and then once the stabilization has been proven, you go in and put either a toric ICL or a normal ICL, depending on the patient's refractive health. Now, eligibility criteria. Now, you will see it seems a little funny. At this point in my talk to put in this slide, this should have come way before. But the reason I'm going to tell you, I'm going to go through the points first. Age more than 18 years, they've done it in younger patients also. They've done pediatric patients also. You need to be more careful because they may have a more aggressive hypoplastic response. So you need to follow them more carefully and maybe put them on steroids for longer. But you definitely need to do it in those don't take care of them, can cause auto holes fault. So what we do for taking care of these are, we just fill the troughs. So those are the holes that you see there. Apply a layer of riboflavin on top of the contact lens, and then you get a uniform surface. And I just show it to you on the slide. That's again a trough which is being filled. I'll show you slide view. This is Wallenstein's article which says that even when you're doing a cross-linking, I'm not talking about CSA or accelerated cross-linking in particular, but for all cross-linkings, after you put the
On behalf of our associates, I would like to really thank the delegates for this organization, and I would like to call upon BSc with the Director of Women Institute to give the videos for the speakers and channels. Dr. K. Vasanta, former Cornea Department Chief and former Director of Regional Institute of Ophthalmology, Chennai. Let's chair the session. Thank you, ma'am. Dr. Srinivas Kera, Darshan IIT, Medical Director from Chennai. Thank you so much for being here this afternoon. Dr. Susan Jacob, Cornea Chief, Dr. Agarwal Sai Hospital, Chennai. Thank you, ma'am, for being with us. Thank you.